We have come to the third part of the series on hydroxychloroquine, and this is a secretive part, but with a Socratic element in it. An element of teaching philosophy, talking about the inner meaning of life. And Socrates, Hippocrates and Socrates were contemporary. Hippocrates, the father of medicine, said, primum non nocere, don't do any harm if you can't do any good. I became a trifle wary when I heard through the grapevine that the government is going to procure millions of hydroxychloroquine tablets, as it is considering to treat patients as well as use as prophylactic for frontline medical staffers and preliminary responders. The silver lining behind this overzealous plan, I believe, is the reign of final operation lies in the able hands of an erudite academician and perhaps the most outstanding clinician of our era, our very dear revered teacher, Professor Mukherjee, who has been bestowed the honor to head the expert committee on COVID-19 management in my state. He is a gentleman who has perhaps single-handedly written more prescriptions than all of us cumulatively of the present generation, and I believe would singularly take care of not distributing the drug willy-nilly to randomly one and all. We know that the case fatality of comorbid patients are materially much higher than the average population, with a predilection to people having diabetes. And there has been a lot of reports, Debang study from the novel coronavirus in Wuhan. He said that a lot of patients, around 20% of the patients, developed arrhythmia, and around 7.2% experienced acute cardiac injury, direct virus damage. This was a purely hyperinflammatory injury. We talked about the cytotoxic storm in the previous part. This led to so much of complications that there was also one report published in European Heart Journal saying that a 37-year-old boy developed coronavirus fulminant myocarditis, but was saved with glucocorticoid and human immunoglobulin. So basically, it has tremendous adverse cardiovascular sequelae. Myocarditis, acute myocardial infarction, in precipitating cases of coronary heart disease, so corona with coronary, and heart failure. So hydroxychloroquine in these cases were given in the loading dose of 400 mg twice daily, followed by a maintenance dose of 200 mg twice daily for 4 days. Mind you, if you're doing this, the ECG monitoring is recommended. For doctors, keep in mind QT prolongation, torsity point T, AB block. These have to be kept in mind. Dose has to be reduced or discontinued totally if the QTC is more than 500 milliseconds, or there's an increase in the QT, corrected QT of more than 60 milliseconds. Caution has to be everywhere, and we have to be extra careful if we are using simultaneous antiarrhythmics like azithromycin. Hydroxychloroquine and chloroquine can inhibit the CYP2B6, which can increase the beta blocker exposure. A lot of patients are on beta blocker for hypertension or heart failure. They can have acute risk of bradycardia, PR interval prolongation, and AV block if it is given for a prolonged time, hydroxychloroquine. So, question of pacemaker comes in. We have another issue to talk about here, that if we have a random use of this product, hydroxychloroquine or chloroquine for that matter, there can be that possibility of anti-malarial resistance. And we know that there are spontaneous mutations which have conferred reduced sensitivity to this drug or the class of drugs. There are single point mutations, there are multiple mutations which have happened all across the globe, especially in Asia, Africa, Papua New Guinea, South America. And that has shown that, fundamentally, if you are exposing the drug for a long period of time, the malaria infections, they demonstrate a range of drug susceptibility. And why this happens is that malaria parasite digests the hemoglobin. Large amounts of a toxic byproduct are formed. The parasite polymerizes this byproduct in its food vacuole, producing a non-toxic hemozoin. Now, chloroquine resistance is linked to multiple mutations in the PFCRT. That's a Plasmodium falciparum chloroquine-resistant type, a protein that likely functions as a transporter in parasites' digestive vacuole membrane. It is believed that the resistance of falciparum malaria to chloroquine is related to the increased capacity for the parasite to expel chloroquine at a rate that does not allow the chloroquine to enter the cell. And it has been referred in the medical hypothesis 15 years back, more than that, 2004, by George Paris, after the fatal epidemic of SARS-CoV-1. And the hypothesis was the prophylactic exposure through apoptotic chloroquine. Apoptosis is programmed cell death, that there is a cell death happening in every cell. And if you give chloroquine drugs, these are actually pro-apoptotic drugs, And they cause natural selection for the strains of viruses and the other parasites that have enhanced anti-apoptotic abilities. When transmitted to host organisms that are not under the influence of pro-apoptotic drugs, like these chloroquines or hydroxychloroquine, the new anti-apoptotic strains may cause unexpected diseases. In the case of SARS, the coronavirus appears to have accessed a new niche where it proves to be lethal to its host. And in that case, in case of AIDS also, the HIV, which has a symbiotic relationship in primates, has run amok because the infected cells are now substantially more tolerant to toxins resistant to apoptosis that they secrete than the uninfected bystander cells, which are not usually resistant to apoptosis. So mind you, there can be a question in the next malaria time, monsoons are coming, we can have a lot of antibiotic or antimalarial resistance from hydroxychloroquine or quinine. There's a study which has been published by M.B. Rajesh Kumar and Chi Dang online on the bioarchives last week, which shows that 30 to 40% of the mice were treated with combination of hydroxychloroquine or chloroquine with the diabetes drug metformin, and 30% or 40% they died. The treatment with the same dose of either drug, metformin, which is considered to be an anti-cancer drug also, or either hydroxychloroquine or chloroquine individually, they had no effect on the survival of the mice. Now, this experiment was actually modeled on the premise which arose from the notion that both these drugs individually are shown to have anti-tumor effects in pancreatic cancer. And because of the new generation of anti-diabetic agents, we have a lot of more pancreatic cancer, or the issues of pancreatic cancer being talked about. So this was a trial which was happening in the US, and this data has been found. So, which was actually in contrast to the single treatment groups, which was doing very well. And when these two drugs were combined, they did horribly. The American Association of Ophthalmology clearly states that the risk factors for development of retinopathy are use of hydroxychloroquine more than 5 milligram per kg body weight, use of more than 5 years, pre-existing kidney disease, maculopathy, or simultaneous tamoxifen therapy for some reason like breast cancer. If you have risk factors, then there will be ophthalmological screening, not naturally at baseline for everybody, not with high risk. But if you are at high risk, it should be done every year to keep a check on the eye. So these are the things that we need to know when we are writing hydroxychloroquine at the granular.